फोन साइलेंट.
अच्छा फोन से. ये देखो आपकी ENT की किताब. ENT डींगरा. कई बार ऐसा.
नहीं स्टार्ट कर दो फिर. Hello everyone, I'm Dr. Sarvejeet and I'm with Dr. Rajesh Kaushal, and in this ongoing series of Dream Duo Marathon, we are here to discuss the integrated questions of ENT and anatomy. So welcome you all to this session. Right sir, shall we start?
Yes, so we are hopeful that in this short duration, we'll be able to cater some of the requirements of the students, basically connecting ENT towards the anatomy subject. So we'll be taking care of some clinicals, and then I can explain some of the anatomy, then hand it over back to Dr. Sarvejeet so that he can continue with the clinics.
Right sir. So let us start with the first question straight away. A 28-year-old male patient, Mr. Pushparaj, came to the hospital with severe headache. Okay, so a patient has severe headache and fever for the past few days. Now, the patient had previous history of ear discharge for several years for which he sought no treatment. So, we know over here, no treatment was sought over here by the patient. Fever with daily fluctuations exceeding 2 degrees Celsius. So, very important over here, 2 degrees Celsius, but at no time touches normal. Okay. On external examination, pitting edema is seen on the mastoid surface. TM examination finding shown below. Okay, so we can see over here, this is the tympanic membrane finding. Otoscopy has been done over here, and we have a photograph. So, before going to the question, let's see what the examiner is trying to tell us over here. I have not still read out the complete question. So, we have in all a few hints. Okay, so severe headache and fever, there is ear discharge. And I always tell my students, whenever there is a ear or a nose patient with headache, so remember head is involved. So there is a intracranial complication. Okay, so I always say ear or nose problem, headache patient has, so head is involved, the cranium is involved. So intracranial complication, okay, for which he sought no treatment. So obviously no treatment has been sorted, there has to have some complication. Now he is having daily fluctuations in the fever exceeding 2 degrees Celsius, but no time touches normal. So this is not intermittent fever. This is
type of
yes. This is yes, sir. This is remittent fever.
Because it is not touching the baseline.
This is not touching the baseline. On examination, pitting edema is seen on the mastoid surface. So I'll come to this question. Which of the following is directly responsible for edema over mastoid? So we'll come to this question. That part I'll leave for the sir. So first thing is picket fence fever, also known as remittent fever. Okay, so if this is the baseline over here, the fever is over here, it has formed a new baseline, it is having fluctuations more than 2 degrees Celsius, but it is not coming back.
Never reaching the base.
Never reaching the base. So this is a remittent fever. Then we have Grisinger sign. So remember, I tell some stories in my lectures. So there is pitting edema over the mastoid surface. The girl who is a singer. Okay, so if you remember what I'm trying to say from a story I told in my lectures. So there is pitting edema over the mastoid. That's Grisinger sign. And we have an attic retraction pocket over here with, we can see, cholestoma. So this is a case of cholesteatoma, okay, aticoantral disease, right? CSOM, aticoantral disease with intracranial complication. And what intracranial complication are we suspecting over here? We are suspecting sigmoid sinus thrombosis. Okay, so 3 reasons. Number 1, it's a clear case of CSM with cholestoma. It can have an intracranial complication. Number 2, picket fence fever. And number 3 is Grisinger sign. right? So over to you, sir. Let's go back to this question. Which of the following is directly responsible for edema over mastoid?
Okay, so I'll be taking care of this question as well, but according to anatomy also, I will discuss some of the details of dural venous sinuses, and then we can come to this question trying to find our answer. Plus I have one question from anatomy as well, because it is a coordinated session. So there should be some anatomy questions along with the clinical questions, though it is of course the gray area, anatomy, the gray area and ENT, which most of the faculties, they don't teach actually. So that is the purpose of this session in fact.
This one, sir.
Right. So this is a question sir has presented to us, and okay, and what about my question? My question is here, it is asking tributaries of internal jugular vein. In continuance of what sir has described, there will be some test also, like if there is this sigmoid sinus thrombosis, it might be affecting the region of internal jugular vein, and if the thrombosis is extending towards the internal jugular vein, or if it is extending intracranially towards the confluence of sinus, there can be different signs. So that we will be discussing, but at the moment, if this question is asking internal jugular vein, what do you think could be the answer? And for that purpose, let us first look at the structure of the dural venous sinus. That will be more important. You will notice these diagrams, we continue discussing, but at this moment we have this importance of looking from the front view at the dural venous sinus, superior sagittal sinus, which is at the upper level and running anterior to posterior, and it is intradural, between the two layers of dura mater. Now the scalp, you see, is outside, and deep to that is skull bone. So let me mark the skull bone here. Say this region is the skull bone. Now you will find, like in this question, we'll require the knowledge of emissary veins. The emissary veins are basically connecting the scalp with the dural venous sinus. And as sir has suggested, the question was on sigmoid sinus thrombosis. From there is one emissary vein, mastoid emissary vein. And if there is a sigmoid sinus thrombus, it might be blocking the extension of thrombus into the mastoid emissary vein, and that will lead to that Granger sign sir was telling, mastoid edema. So that happens. Why? Because there is a blockage of mastoid emissary vein, which is connecting to which sinus? Here it is superior sagittal sinus, as I am talking about, but in our case, on the mastoid, near the mastoid will be sigmoid sinus. So here, what is the structure basically? You will find that the deep to the skull will have what is called as, say, the dura mater, and dura mater has double layer. Towards the skull there will be endosteal layer, and towards the meninges there will be meningeal layer. And when we are talking about this endosteal layer, you see it is following the bone, but the meningeal layer is separating. And when the meningeal layer is separating, let us say we are representing it with this color. As the meningeal layer and dural layer, they are basically fused, but they are separating, and when they separate, you will find there is a falx cerebri here, separating the right cerebral half from the left cerebral half, plus this layer, meningeal layer, again goes back and fuses with the endosteal layer. This is the dural venous sinus we are talking about. It is intradural space. Now what does it contain? Of course, some venous blood of the brain. You see, the venous blood of brain will keep going here like cerebral veins. Plus, deep to dura mater, we have the other meninges, which we are calling as the arachnoid mater. And what is deep to arachnoid mater? We have a space, subarachnoid space. So there will be CSF here. And when we are talking about that CSF, you notice this CSF, which is in the subarachnoid space, is also moving into this dural venous sinus, what is called as the arachnoid granulations. It has importance because in sigmoid sinus thrombus, if you have compressed this internal jugular vein on one side, there will be one side, say for example, let us say one side is already thrombosed, and the other normal side you are compressing.
Yes.
You are basically blocking the venous drainage. And not only the venous drainage, you are raising the CSF pressure also. So how will it present? There are some signs I will be telling you, like papillary edema could be there. Or you are doing a lumbar puncture. In that lumbar puncture, there will be some variations sir will be discussing. So basically, the intradural space, and which contains, of course, venous blood, but CSF pressure can also be elevated if you are blocking what is CSF basically? Ultra-filtered blood. And that ultra-filtered blood has to go back to the venous side and to the heart. Ultimately, all the blood has to go back to heart for pumping. Okay, so once we have discussed this, durometer, arachnometer, cervical space, and what will be the last thing here? As we understand, that will be the pyometer covering the brain structure. Now, this is one thing which we wanted to focus upon. Let me take you to this diagram now. See, normally what we have to understand is, say there is, looking from a side view, and these are some dural venous sinuses we were talking about, and here, you see that cavernous sinus is basically deeper level, and otherwise there is superficial level, like this is the superior sagittal sinus coming here, and then there is inferior sagittal sinus, which is in the falx cerebri, which we just described. It is a double fold of durometer and having some dural venous sinuses. Above, superior sagittal, below, inferior sagittal. Now, around the brainstem, you have a internal cerebral vein, and they join to form great cerebral vein of Galen. So, brainstem, internal cerebral vein, great cerebral vein of Galen, join with the inferior sagittal sinus to form straight sinus, and straight sinus then joins with the superior sagittal sinus. From below comes the occipital sinus. So here you can remember SOS, which is confluence of sinus. The first S is superior sagittal sinus, the O from below is occipital, and from the front it is straight sinus. And from here, which is on the internal occipital protuberance, you'll have the transverse sinus becoming sigmoid sinus and continuing as the internal jugular vein. So as you find, this is,
Sir.
yeah.
So I have a small story for everyone. Just reminding the story. This is the superior sagittal is the father. The inferior sagittal is the son. He marries a great girl, great vein of Galen, and he becomes straight in his life. Okay, the occipital sinus is the mother. All of them, they drain the blood at this point, the confluence of sinuses. Now from here we have two grandsons, which are known as transverse sinuses. They are married to a daughter of cavernous sinus, the superior petrosal sinus, and now he becomes curved once again, which is then known as the sigmoid sinus. And this sigmoid sinus, while going out of the jugular foramen over here, it gets to marry the younger daughter of the cavernous sinus, the inferior petrosal sinus, and it becomes straight once again. So marriage changes the characteristic of man. Straight becomes curved and curves become straight. And this is how we remember these sinuses.
Great. Stories will always help us to recall better. And ultimately, so what we wanted to know was, see, sigmoid sinus as such is at the junction of transverse sinus and the internal jugular vein. And inferior petrosal sinus is the first tributary to the internal jugular vein. And that is what my question was. Let us go
and
back.
Sir, my question over here was that this sigmoid sinus has an extramarital affair with a girl who's a singer. So the extramarital EM is the mastoid MS3 vein, and the girl who's a singer means Gressinger sign, edema over mastoid by this vein. Okay.
Because there was internal ear infection, middle ear infection,
Right, sir.
polystatoma, and because of that there is sigmoid sinus thrombosis, and that is extending into mastoid MHT vein. That is why you're putting sign over the
Yes, sir.
mastoid.
Because of that
Okay,
only.
so mastoid MHT vein.
Yes.
And that will be the answer to your question.
So because it was asked directly responsible, so answer will be mastoid MS3 vein.
Right. And if we are talking about my question, what is the tributary to internal jugular vein? Then you can understand yourself what could be the answer. Internal jugular vein, the very first tributary, right at the beginning, is the inferior petrosal sinus. And that is my answer. If we go back to sir's question, which is, here, we started with that only. So, which is the vein which is responsible for the edema over the mastoid. So you already know, sir has already told extramarital affair. So with whom? That is the choice number C here, as we will find this should be our answer. Okay, so
All
sir,
right.
we can move on to the
So
next
yes,
question. So I'll take from here.
yeah. Okay, so we've discussed all this, and sir has discussed all this with you. Just a quick, when you do a lumbar puncture and you measure the increase in CSF pressure, remember you have to block on the normal side. So if the right side is thrombosed, you have to block on the normal side, and then only the CSF pressure will be increased. Okay, that is known as Quicken test or the Tobbe-Ayert test. This is an invasive test. You can also do a non-invasive test, that is the Croback test, where you see for engorgement of retinal vessels. Again, you have to block on the normal side. It's a non-invasive test, right? And the test for the diagnosis, the diagnostic test is we can do a contrast enhanced CT scan, or we can do an MRI, and we get to see a empty delta sign. Right, sir? Okay, so let's go to the next question over here. This question has been discussed by sir. Question number 3, a 21-year-old female, 21-year-old female patient, Mrs. Priyanka, was admitted in the medicine ward for treatment of meningitis. So we already know this is a patient of meningitis. A consultation call was sent to the ENT department as the patient complains of giddiness while walking, along with continuous ringing sensation in the ear. So we know that with meningitis, the ear is involved, okay? On examination, patient has sensory neural hearing loss and labyrinthitis is suspected. So my ENT diagnosis is already there. We are suspecting labyrinthitis. That has been mentioned by the examiner over here.
Meningitis, labyrinthitis.
So meningitis, so it is clear that the patient has meningitis, and from meningitis it has further gone to become labyrinthitis. Okay, now which of the following is the most common route of spread of infection from brain to inner ear? Sir.
Yes. So there is a correction which we have to talk about. Let me take you back to my slides. Say now what we have got is, sir has given us this question, and even I have one anatomy question before I come back to the answering this question. My question is here, which of the following is opening into the intradural space? Now, if you read ENT books like Dingra, you'll find that there are two terms used. At one place, they will say endolymphatic duct, the sac, opens in subdural space. At other page, it is written opens between the two layers of dura mater. So, you should not say subdural, you should say intradural. But the thing is, if you do not have the option of intradural, then you can say subdural. Yes. So there is always, because you have to strictly follow the books, and standard books are there. So subdural is okay, but if a better answer is the intradural. Let me show that in a diagram also. But here, which of the following is opening into intradural space? And I already mentioned, must be we are talking about endolymphatic duct. Now, sir has discussed one case of meningitis. What is meningitis? Dura mater stays outside. It is basically leptomeningitis most of the time. That is, the arachnoid and pia mater, they are inflamed. There may be inflammation, there may be infection also. And it is about something, labyrinthitis means labyrinth. Labyrinth means inner ear. We are talking about inner ear. Embryologically, what is the structure of inner ear in the beginning? Let us look at this diagram. Here we understand that in the beginning, there will be, say, a bony labyrinth outside, and inside that there is a membranous labyrinth. So when we are talking about the membranous labyrinth, what is it filled with? Inside, endolymph. And what is outside that? Within the bone, but outside membranous labyrinth, that is perilymph. And somehow it is seen that perilymph, sir has explained beautifully in his lectures, but perilymph is having more of sodium ion, and the endolymph is having more of potassium ion. There is some pump, sodium potassium ATPase pump, and sir has a story basically, a girl, a boy going into a discotheque, something like that. But at the moment, my purpose is that this perilymph, which is there, see, perilymph or endolymph, what exactly they are? ultrafiltrate of blood. You can say ultrafiltrate of plasma also. And in that context, we have to mention here, let me just say, if we are talking about the perilymph, it is going to be continuous with the CSF space, basically subarachnoid space. So you can say in a way that it is, and what is in the subarachnoid space? CSF, ultrafiltrate of blood. So that CSF, which is in the subarachnoid space, is somehow communicating with the perilymph space. What is that communication? That is called as aqueduct of cochlea or cochlear aqueduct. Now, if this is the cochlear aqueduct, there is a vestibular aqueduct also. Inner ear is two components, cochlea for hearing and vestibule for balance. So if you have a cochlear aqueduct, there will be a vestibular aqueduct also. What is there in the vestibular aqueduct? We will find that the endolymph is also having a communication, but it is a blind end basically. So endolymph is having a duct again, but this is vestibular aqueduct, and in that you will have endolymphatic duct, which will then become endolymphatic sac, and which is a dead end basically. This endolymphatic sac is the one which opens intradural. This was our question. So let me show that in a diagram also. We are talking about labyrinth, the inner ear, and where do we see that? If we go anatomically, you are looking from the superior view now, and superior view you have taken out the brain. Look into the cranial fossa, anterior cranial fossa, middle cranial fossa, posterior cranial fossa. There is a petrous temporal bone here, and as we talk about this petrous temporal bone magnified here, you will notice that inside the petrous temporal bone you have the inner ear, and if you are talking about cochlea, more anterior, and if you are talking about the vestibule, it is slightly posterior, and these are the three semicircular canals, slightly still posterior. And if you magnify this area, this is bony cochlea. Remove the bone, you will have membranous cochlea. So the yellow color which you see is bony, and blue color which you see is the membranous. So endolymph will be inside the membranous labyrinth. You will find that the endolymph is coming out here in a blind sac, and that is endolymphatic duct, endolymphatic sac, and it is the structure which we were talking about on petrous temporal bone, intradural, though some places it is written as subdural. And what is the purpose of this? See, when you talk about endolymph, the structure which is here, the cochlea will have stria vascularis, and stria vascularis will be giving us endolymph. Now, if stria vascularis is giving us endolymph, where is it getting absorbed? Because it is all ultrafiltrate of blood. Blood must go back to the heart for pumping again. So where is the drainage? Some books say stria vascularis can absorb also. But see, the better thing will be, you remember that whatever the stria vascularis in endo has secreted the endolymph in the cochlea, that endolymph is coming here, and then it is going into ductus reunion so that it can meet with the vestibular endolymph, cochlear endolymph, vestibular endolymph, and then this is the endolymphatic duct we are talking about, which will be in the aqueduct of vestibule, because this time you are in the region of vestibule. Aqueduct of vestibule. This is the aqueduct of cochlea, because here we are coming from the cochlea, and then this is endolymphatic sac which is opening here. Now again, let me show here. You see, there is one layer of endosteum. This is the brain basically. If this is the brain, then what will be filled here? That is the CSF.
This is the subarachnoid.
Okay, subarachnoid space. And then we can mark here, say, if this is the brain, subarachnoid space, then this is the double layer of dura mater.
Right.
And this double layer of dura mater splitting and enclosing the sac which is there, endolymphatic sac.
Right.
So some of the absorption into capillary plexus can be happening here. This is the question we were having. Endolymphatic duct or sac, where does it open? Intradural or subdural? Better is intradural, but if not given, subdural is okay. Now what about the perilymph? This yellow color perilymph, if you are following, you will see that the perilymph which is here is having a communication, you see here, and this communication is going into subarachnoid space. That is where the description comes. The pyometer, arachnoid mater leptomeningitis is infected or inflamed. From there, the CNS infection can move through this communication, which is basically the cochlear aqueduct, and then causing labyrinthitis. So that was our topic of discussion. CNS infection can move into the cochlear system via which communication, and that was our question. If you look at the question again, this is the question they're asking. If you have got this lady who is having meningitis, and then there is labyrinthitis, so what is this structure which is bringing the infection from brain to inner ear? So what do you think is the answer? Sir can take over from here a little bit.
So the answer, sir has already told you, is the cochlear aqueduct, right? But some of you might have got confused with cochlear duct. So the cochlear duct is nothing but the other name for scala media. Strategically placed at B option to confuse you, okay, to confuse you between these two options. Ductus reunions again, sir has shown you. Okay, let me go back over here and go back to this diagram that sir was explaining to you. So we have this cochlear aqueduct. We have the endolymphatic duct going into the endolymphatic sac. The ductus reunions has been told to you. So this, the endolymph, this is the scala media and the cochlea, that is known as the cochlear duct. Right. So that was all to be told in this question. Right, sir. So let's go to the next question, shall we? So this all we have discussed. This is the same photograph in another view. Okay, so where all these things have been mentioned to you.
Mine was inverted.
Yeah, yours was inverted and mine is this one. So you can see over here that the endolymph is going from the cochlea into the saccule through ductus reunions, okay? And from here, the saccule and the utricle, they combine, the endolymph over here combine, and this forms the endolymphatic duct, which goes over here into the endolymphatic sac. It is intradural.
That was my question.
Yeah. So there's a lot of confusion, but you remember that as an ENT surgeon, we cut and operate, we do endolymphatic sac decompression, and we cut a layer of the dura to go into this sac. Right. Okay. So few more words about labyrinthitis. It can be a serous labyrinthitis when only the toxins they reach the inner ear. Now the problem over here is the sensitive hearing loss, but it will be reversible. Okay, right? But how will you clinically identify it? Because this you can see in retrospect. So how do you identify? You identify it with nystagmus is to the same side. Okay, and then we have the suppurative labyrinthitis where the bacteria goes in the inner ear. Now this is going to be irreversible sensory hearing loss, and now the nystagmus is to the opposite side. So this is how we clinically identify that the nystagmus is to the opposite side. One more last thing is labyrinthitis ossificans. Now this is an entity which follows later on labyrinthitis, where the inner ear starts undergoing ossification. So post-inflammation, there is calcification and ossification, and we have over here white out inner ear, and this leads to a progressive sensory hearing loss after an episode of meningitis or labyrinthitis. Right, sir. So let's go to the next question over here. Go to question number 5. A 37-year-old male patient, Mr. Satish, presented in emergency with complaints of severe sore throat, difficulty in swallowing, and ear pain for the past 2 days. On examination, he is having a muffled voice and his mouth opening is less than 1 finger. Okay? Trismus. Severe trismus, sir. Less than 1 finger means severe trismus.
And sir, this is hot potato sign?
Yeah, so muffled voice means hot potato voice. Which of the following masticatory muscle is likely to be responsible for decrease in mouth opening? So what do you think we could have made the diagnosis with severe sore throat, difficulty in swallowing, and ear pain? Rhaphidotalgia. Okay, so I have 2 diagnoses in my mind. Number 1 diagnosis that comes into my mind is quinsy.
Peritonsillar abscess.
Peritonsillar abscess. Number 2, the same presentation can also be seen in case of parapharyngeal abscess.
If it is rupturing and moving laterally.
So even that is possible that the quinsy has gone into the parapharyngeal space, and Because of that, we have these symptoms. And in fact, if there is trismus, now
That is where you have these muscles, sir.
yeah, in fact, this is what I wanted to say. Whether in this history, whether the patient has quinsy or the patient had parapharyngeal abscess to begin with is insignificant. Now the patient has both. Okay, because the trismus itself tells you, severe trismus itself tells you that the quinsy has spread to parapharyngeal space. Okay, how? I think sir is a better person to explain that thing.
Sir, here, as you are explaining, because tonsillitis, peritonsillar abscess can go lateral into the masticatory space, and the muscle which is in immediate contact, if it is something like parapharyngeal abscess, which muscle is that? The mandible, ramus of mandible, outside is masseter. What is inside? What is inside is, so we'll come to this diagram.
Okay.
But here, let me give you one mnemonic. There is this mnemonic MTM elevators. They elevate the jaw and close the mouth. M for masseter, and the T for temporalis, and M for medial pterygoid. These three muscles, if they are in spasm, they will cause trismus, not the lateral pterygoid. Lateral pterygoid is basically a depressor of the mandible. It opens the mouth. So trismus or lockjaw or spasm of the mouth, so that sir is telling it is quite severe. It is just admitting one finger.
So less than one finger.
Less than one finger. So this is where we have to focus upon, and I am suggesting that parapharyngeal space is immediately exposed to medial pterygoid. So that should be our answer. See, normally when we talk about the trismus, what do we think of? We think of masseter like in tetanus neonatorum, the baby, mother is feeding the baby, milk, baby is not taking the feed. So normally we discuss about masseter, which is responsible for the trismus. But here, you have to be careful, it is medial pterygoid. Now, how it is medial pterygoid? Sir has one diagram, the same diagram I have. So let us move on to that discussion. So this is sir's question, and even I have got one question, which is from anatomy. It is actually about the same thing, parapharyngeal, retrofrangel spaces, danger spaces, fascia. These are some questions which are appearing quite frequently, and especially JIPMER people used to ask such questions. Now JIPMER has been merged into INI-CET, and that doesn't mean that JIPMER professors will be excluded. They are in the team, and definitely they'll be contributing for INI-CET, because even the students which who are getting selected in INI-CET, they have to go to JIPMER. So JIPMER professors must, and they have very stringent. Their standards are very high. So anyhow, as you look at this question, it is asking if we have got a retrofrangel abscess, which is behind. See, retro is behind, para is on the side. Parapharyngeal, retrofrangel. And then it is between which two layers. So here we have to talk about the fascia. In the neck there is deep cervical fascia, and deep cervical fascia, when we talk about, we can discuss numerous terms, but in the beginning you will have only three of them. Let me show that deep cervical fascia in the neck in a diagram. That will be better way of explaining. So as I take you further, say this is one lady we are looking at, and the three layers of deep cervical fascia, if we are talking about, the one which is most superficial, like a sleeve, like cloth over your body, it is investing layer of deep cervical fascia. It is like a circle.
Enveloping or investing.
Enveloping everything almost. So deep cervical fascia, investing layer. Now, if you still go deeper, you'll find two more circles. Let me just zoom this a little bit, and you'll find two more circles. So as you will notice, there is one fascia which is around the two tubes, one which is called as the respiratory tube, and the other which is called as the gut tube. So there are two tubes which are running.
Trachea and esophagus.
Like you have trachea, so like larynx becoming trachea, pharynx becoming esophagus. So these two tubes, around that you also have a fascia. But the thing is, in the beginning, since it is in front of the trachea, we call it as the pretracheal fascia. So what I'm talking about, see, number one was investing layer of deep cervical fascia. Number two, it is pretracheal layer of deep cervical fascia. Now this pretracheal, because it is in front of trachea, we say pretracheal, but it has further subclassification. And somehow this pretracheal fascia, when you are following this around the gut tube, it gets a modification, is called as buccopharyngeal fascia. So if you are talking about buccopharyngeal fascia, it is basically subclassification of pretracheal fascia, but when it is in relation with the pharynx or maybe esophagus. Now in the pharynx, you know, there is a muscle. There are three muscles basically: superior pharyngeal constrictor, middle and inferior pharyngeal constrictor. They are constricting the pharynx so that whatever we are eating, the food bolus should keep going down, 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 deglutition. Superior pharyngeal constrictor. It is gut tube. What is the lumen line by? Mucosa. What is outside the mucosa? You have submucosa, then the muscular layer, and then the adventitia. Outside that, you have this structure, what is called as buccopharyngeal fascia, because it is deep fascia of the neck. So must be outside the viscera. Now, this is the buccopharyngeal fascia. So number one, we have discussed investing layer, which is a big circle here. Number two, pretracheal fascia, which is again a small circle, and its subclassification was buccopharyngeal fascia. Now, the third circle. And you know, behind the neck, what do we have? We have the vertebra. And if we are talking about the vertebra, in relation to vertebra, we have another circle. And as you're talking about that circle, let us take some other color. Say, now this circle is around the vertebra, and that is prevertebral fascia. So number three, we have prevertebral fascia because it is in front of vertebra. Say for example, cervical vertebra. So cervical vertebra, around that, it will be enclosing the paravertebral muscles also. So one big circle, investing layer, another circle anteriorly, the pretracheal layer, and the third circle, that is prevertebral fascia. Now this prevertebral fascia.
Sir, may I add to it this thing?
Yes, please.
Okay, so what we say in ENT over here, we have the three layers as sir has described. The number one is the superficial layer of deep cervical fascia. The second one sir has described is the middle layer of deep cervical fascia. We split it into two layers, sir. We split it into the first layer, the muscular layer, and the visceral layer. The muscular layer encloses the strap muscles.
Right.
Yeah, the sternohyoid and the sternothyroids. And then the visceral layer encloses the thyroid, the trachea, and the esophagus. Behind the pharynx or the esophagus, it is known as buccopharyngeal fascia. Right. And this one we call as the deep cervical fascia, and this also splits into two layers.
So that there is one anterior layer, which you will be calling as, say, this is the prevertebral fascia.
Yeah.
It splits like this, and then there is one proper prevertebral fascia, prevertebral fascia
right,
proper,
sir.
and there is one which comes anterior, alar fascia. So let me just draw this diagram in a simplistic way. The prevertebral fascia again splits into one layer, anteriorly, one posterior. Posterior is the proper prevertebral fascia and then alar fascia. Between the two, you have danger space. Now, why do you call it as danger space? Because any infections, any inflammations can move downwards. DD, remember DD, danger space till diaphragm. It can take the infection from neck region till the diaphragm level, DD.
Directly
danger
to the mediastinum.
Space till the diaphragm. So that is a problem. Neck infections reaching the mediastinum, mediastinitis is there, diaphragm is irritated, all that. So as we are...
So one more thing,
yes.
The prevertebral space, many students they get confused.
Right.
It is prevertebra. Okay. It is behind the prevertebral fascia. It is between the vertebra and the prevertebral fascia. So this is the space.
So there are three fascia and three spaces,
right, sir,
which we have to basically focus
right,
upon.
Sir.
And in a simplistic way, if you let me draw a diagram, say in a simplistic way, what we can do is, we are telling that there is one investing layer of deep cervical fascia.
Right, sir.
And then there is one which is pretracheal fascia, which was actually modified posteriorly so that we were calling it as the buccopharyngeal fascia.
Right, sir.
And then we have this prevertebral fascia which split so that we could have one alar fascia.
Right, sir.
So three fascia and 3 spaces basically.
Right.
Now vertebra is here. Let us say this is the vertebra. And what about the spaces? See, vertebra is there. In front of vertebra, you'll have some space. And in front, that is why it is called pre-vertebral. Let me change the color. Say this is pre-vertebral space. Space number 1.
Right.
Space number 1, pre-vertebral space, as sir was explaining,
Yes.
in front of vertebra, but behind the pre-vertebral fascia proper. Now, space number 2. This is danger space. So, danger space is between what? It is, see, in ENT, Dhingra it is written that it is related to pre-vertebral fascia. But another layer is split. The anterior is alar fascia, posterior is pre-vertebral fascia, but proper. So danger space is between, or you can say within the layers of prevertebral fascia. Anterior layer, alar, A for A. Anterior is alar, and posterior is proper, the prevertebral fascia proper. So these are 2 spaces. What is the third space? Behind the pharynx. Because we have told that this is pharynx, behind that you have buccopharyngeal fascia, isn't it? So this was the pharynx tube, this was the larynx tube, the respiratory tube, gut tube. So where is this third space and what is the name? Behind pharynx, so what will you say? Retrofrangel space. Retrofrangel space. So 3 fascia and 3 spaces. What are the 3 fascia? Prevertebral, alar, and buccopharyngeal. So as you enumerate the fascia, number 1, you can say prevertebral fascia proper. This is first. Number 2, this is alar fascia. And number 3, it is buccopharyngeal fascia. 3 fascia and 3 spaces within them. If it is vertebra and prevertebral fascia proper, the prevertebral space. If it is alar fascia, prevertebral fascia proper, then danger space, which is going till diaphragm, and retropharyngeal. So retropharyngeal space infections can reach to which level?
Sir,
inferiorly?
sir, before I go and answer that question for you, I'll add one more thing over here, is that this buccopharyngeal fascia, it condenses over here.
Yes, raphe.
That's it.
Raphe.
So there's a midline raphe, it condenses over here, and because of that, we don't have one retropharyngeal space, we have 2 retropharyngeal spaces on right side and on left side.
That is why retropharyngeal abscesses will be unilateral.
Yeah, so they will form an abscess like this on one side of the posterior pharyngeal wall, whereas a prevertebral space abscess will form a midline swelling like this.
Like there is a tuberculosis of vertebra,
Yes.
cold abscess,
Yes, sir.
and that cold abscess will be midline
Yes,
abscess.
yes. And the retropharyngeal space, it generally extends to the level of T2, second thoracic.
T2, right. Till tracheal bifurcation, some books will say,
Yeah.
but T2
T2.
is good.
Yeah.
Now, let me just a little bit of time, which is actually your territory now. See, maybe it is a transverse section, but you can imagine looking from front view, tonsils. What is behind that? Retropharyngeal space. What is behind that? The danger space.
So,
and what is
sir-
behind that? Yes.
Sir, you can just enumerate, and I'll just
Right.
I'll
Yeah.
color it.
Okay.
Okay, so this is the retropharyngeal space, sir is saying. Okay,
3 spaces basically.
And behind that, this is the danger space that is there, and this is the prevertebral space with the muscles in it. Okay, so that is the prevertebral
So
space.
you can see prevertebral, number 1, and number 2, it is the danger space, and number 3, it is the retropharyngeal space. 3 spaces and 3 fascia. And when you are talking about the 3 fascia, what is the most anterior which is behind the pharynx? That is buccopharyngeal fascia. It is a subclassification of pre-tracheal fascia, deep cervical fascia. So first fascia. What is the next fascia? That is the alar fascia, number 2. And what is the third fascia? Prevertebral fascia, which is proper. So as you see, vertebra, then you have prevertebral space, prevertebral fascia proper, then you have the danger space, alar fascia, which is a subclassification of prevertebral fascia, then you have retropharyngeal space, and then you have buccopharyngeal fascia. Where is this one more fascia which relates with the pharyngobasilar?
That is this over here.
Between mucosa of the pharynx and the superior pharyngeal constrictor. So this is the superior pharyngeal constrictor. The muscle which you are seeing here is, if it is deeper to muscle, then it is the pharyngobasilar fascia.
Yeah.
If it is exterior, then buccopharyngeal fascia. Now, coming
So
back
I
to-
always say near the pharynx, pharyngobasilar, pharynx से बाहर तो buccopharyngeal.
Buccopharyngeal. And sir, this was your case. There was one infection with the tonsil, peritonsillar space, which is between the capsule of the tonsil,
And the superior constrictor.
superior pharyngeal constrictor.
Yeah.
Abscess is there. There is ninth nerve supplying tonsil, ninth nerve
So
supplying
ninth
tympanic
nerve is
branch,
here. Ninth nerve is here.
Ninth nerve supplying tympanic. So there is
Yeah, so
referred
it is
algia.
the glossopharyngeal is going lateral to the superior constrictor over here.
So referred algia. Plus this is the medial pterygoid, and medial pterygoid on the ramus of the mandible. Masseter is outside. So medial pterygoid in close approximation. That is why trismus involving
And
medial.
sir, this space is the parapharyngeal space.
Right.
So if this quinsy will go to the parapharyngeal space, especially anterior to this styloid apparatus. That's the styloid
Three
apparatus.
muscles attaching to
Yeah,
styloid.
yeah. So this is the anterior compartment of the parapharyngeal space, and if this will go, it will obviously go in the anterior compartment, and from there it will cause the
Medial pterygoid
spasm.
trismus, because these are MTM elevators.
Right.
They elevate the jaw so much that it was, very severe, as you have mentioned.
Yes. So I anyway said if it's a quinsy or if it's a parapharyngeal space, it has to be the anterior compartment and the only muscle that will cause the trismus. So in this question, the differentiation does not matter. What matters is the severe trismus. So if a quinsy patient has severe trismus, that automatically means the infection has spread to the parapharyngeal space and then has caused the medial pterygoid spasm.
Right. So we can move on to the next question.
Yeah, so let's move on to the next question. So we have seen all this, the vertebra, the peritonsil.
Same diagram, sir.
So same diagram, we have discussed all of this. Okay, and right. So let's go and discuss the next question. A 14-year-old male, Mr. Jaideep. So over here, the 14-year male patient, Mr. Jaideep, presents in emergency with complaints of severe recurrent epistaxis for past few weeks. On examination, patient is anemic and a swelling is present in his right cheek. Okay, so first thing over here, teenage group, male, recurrent epistaxis.
More of testosterone, sir.
Yeah, so this is the first DD we have to take is the JNA, juvenile nasopharyngeal angiofibroma. As I've always told you, teenage group, male epistaxis, first diagnosis is JNA unless proved otherwise. So let's go ahead. Anterior anoscopy showed a reddish fleshy mass in the right nasal cavity extending into the nasopharynx. So the history and then the examination is clearly pointing towards the JNA. Okay, so what do we do for confirmatory? We do CECT. So you see even CECT was done and it revealed an enhancing dumbbell-shaped mass in the nose, nasopharynx and extending up to infratemporal fossa. So the CECT, they have clarified everything. It is of course the case of JNA. Now we have confirmed that. Which of the following structure has been crossed by this mass to cause cheek swelling? Okay, so in fact they have mentioned it is going to the infratemporal fossa and that's why he's having a cheek swelling, but which of the following structures has been crossed?
Superior fissure, inferior fissure to the orbit, telego maxillary or telego palatine. Okay. So we'll come back to this question to find the answer. Let me just give you some details about this area. Say we are talking about this question, and sir, because these are males, we give them female hormones, DES, diethylstilbestrol and all that.
We give them, but that's the chemotherapy is one of the last.
Before you start removing the.
No, not before.
Okay.
Not before. Only in recurrent cases.
Recurrent cases.
Or in cases where it's going intracranial, then only we give.
Okay.
Otherwise, the treatment of choice
Just
is.
to reduce the level of
Yeah,
growth.
so-
Angiofibroma means basically blood vessels are highly vascular.
Yeah.
And even before surgery, if you want to, I have read somewhere 2 liters of blood is lost when you are operating.
So yeah, when the open surgeries were done, we will be losing 1.5 to 2 liters. That was the usual case. So we'll have 2, 3.
Out of 5 liters, you are losing 2 liters.
Yeah, so and anyways, and that's not out of 5 liters. You have to understand that these patients have bled so much that they are already anemic. So as over here, so patient is anemic. It is mentioned over here. So we can see patient is anemic over here. So we have to transfuse. Sometimes the patient comes with 7 or 8 hemoglobin levels also. We have to transfuse before surgery, intraoperative also.
Right.
But for that we used to do, to reduce the bleeding, we used to do pre-operative embolization.
Okay, so
Oh.
you will embolize the
The
territory
field.
of the area
Yeah.
before you operate.
Yeah, but nowadays what we are doing is we are doing an endoscopic excision of the angiofibromas. Now in that some surgeons go for embolization. I per se don't go for embolization. What we do is we dissect the tissue around the tumor. We first clip the feeding vessels.
Okay.
And then we take out the tumor. So the tumor is almost avascular, and now we have some good equipments. Okay, so this is
When you
coagulation.
finally remove it.
So we have like coagulation, some good instruments where we can control the bleeding also for angiofibroma.
Earlier, I think cryotherapy, radiotherapy. were-
So radiotherapy is still tried. Some forms of angiofibroma are seen to be very, very invasive. Suppose they involve the
Though they are
temporal.
benign.
Yeah, they're benign, but sometimes they involve the
Local local area.
into the brain, the temporal lobe.
Brain.
Okay, then only we give radiotherapy. Otherwise, for most cases, even if they're involving the cavernous and all, we
So I think
can.
they can move into middle cranial fossa. I think.
They move the middle cranial fossa, and if they're involving the cavernous sinus, they're engulfing the ICA. That all is clearly removed by the endoscopic approach. Only once they go beyond that, then we are not able to do that. So we try to remove the maximum, and small part we remove it by cryotherapy or radiotherapy, we give, or sometimes chemotherapy is given.
Right. And even anti-cancer drugs are given, right?
Very rarely, sir, very rarely.
Because anti-mitotic basically.
Yeah.
So it is actually in relation to this particular area. We are actually talking about telego-palatine fossa, which can be quite daunting for the first year MBBS students. But as I was discussing with Dr. Sarvejeet, that once you are an ENT surgeon, then you just start thinking, what is there to be understood? Everything is so clear, nicely. Why are you having problem with telego-palatine fossa? You have to go back to your first year and just imagine that situation. It was a horrible experience when some teacher will ask any question and then like, oh, I don't know nothing. So some relations, is it anterior, posterior, medial or lateral? Now even like before moving on to this answer of this question, let me just take you to this diagram. You are looking from the lateral view now. And when you are looking from the lateral view, basically, see, there is a bone which is covering the roof of the oral cavity, which is called palate, so palatine bone. Now, if you have the palatine bone, what is behind the palatine bone is another bone, which is sphenoid bone. So that gives you an idea, very simple. Anteriorly palatine, posteriorly sphenoid, sphenopalatine, everything, whatever. Sphenopalatine foramen, sphenopalatine fossa, sphenopalatine ganglion. But sphenoid bone is butterfly shape, greater wing, lesser wing. It has legs also. The legs which we talk about is pterygoid process and pterygoid plates. So sphenopalatine name changes to pterygopalatine. Pterygopalatine fossa, pterygopalatine ganglion, pterygo, and then see, palatine bone is forming palate, but then the palate is also contributed by one more bone, which is anterior, maxilla. So maxilla is anterior, palatine is posterior. Then you have this sphenoid, but sphenoid has relation with maxilla because palatine is only in the center, midline. Maxilla is a big bone. So sphenopalatine, if you are near the midline, what if you are away from midline? Then sphenomaxillary or pterygomaxillary. More laterally, pterygomaxillary, sphenomaxillary. So these are some basics basically. Now here, let us see if we are talking about, say, here. This is the pterygoid process, pterygoid plate, the legs of the butterfly, sphenoid. So pterygoid plates of the sphenoid bone, and this is the greater wing of sphenoid. It's a butterfly, greater wing, lesser wing. So greater wing of sphenoid, and then this pterygoid plate. What is this upper teeth in which bone? Maxilla, more laterally. So more laterally,
They are the
it will be the maxilla. But if you go more medially, you can see, first of all, you can talk about pterygomaxillary space. Pterygomaxillary space. But if you go deeper, maxilla is lateral. What is more medial? Palatine. So what will the pterygomaxillary space become? pterygopalatine space. This is the area we are talking about, and that is where you will have pterygopalatine fossa ganglion. And if you still go deeper, you'll find there is this sphenopalatine foramen. See, maxillary artery supply maxilla upper teeth. Third part of maxillary artery is in pterygopalatine fossa. End branch, sphenopalatine artery, artery of epistaxis, passes through sphenopalatine foramen to enter the nose. I'll show you this opening from inside also. This is looking from outside. So this bone is maxilla. Which artery? Maxillary. ENT people say internal maxillary artery, branch of external carotid. So external carotid giving internal maxillary or maxillary artery. Last branch, sphenopalatine. How does it enter the nose? Because it has to supply the nose, quite good supply to nose. Sphenopalatine foramen. So this is from the lateral view. Let me now show you a schematic diagram, that will be better. Now looking at the same way from the lateral view, you see, let me just magnify this further. Now things are more clear because they are shaded. When things become shaded, they become better. So what do you think? This is, as you see, greater wing of sphenoid. Here, this is greater wing of sphenoid. And when you are looking at the pterygoid process, this is the pterygoid process leg of the butterfly, right? This is laterally which bone? Laterally we understand that is the maxilla posterior surface where you have maxillary teeth, upper teeth. But if you go more medial, can you see the blue color there? More medial, palatine bone. So as you go deeper, palatine, and if we are now...
So palatine bone is like L-shaped, like this.
L-shaped.
So paired bone. So this part, the horizontal process, it forms...
Perpendicular and horizontal.
The horizontal forms the palate, the hard palate, posterior part, and the perpendicular plate forms the lateral wall of the nose. So you can see this perpendicular plate over here. Sorry, I just shaded it with blue.
It's okay. So that is palatine, same color we are using, perpendicular plate. And can you see one opening now? So let me just zoom this a little bit more, and you can find very clearly now, you see this opening,
So between sphenoid and palatine.
Maxilla, maxillary artery, maxilla, maxillary artery, third part of maxillary artery in which foramen? Sphenopalatine fossa foramen. Passing through this foramen, lateral nasal wall into the nasal cavity. Let me show that from inside now. That will be better. So as we look at this from inside, and before that, see, if we are making a schematic diagram of this, you can appreciate one fact which we wanted to focus upon. The pterygopalatine fossa. This is the fossa. From here, you can enter the orbit. And as you enter the orbit, you can use inferior orbital fissure.
Yes.
So from this inferior orbital fissure, you can enter the orbit. Actually, you have maxillary nerve, maxillary artery in the pterygopalatine fossa. Maxillary nerve enters the orbit and continues as infraorbital nerve. Infraorbital nerve at the floor of the orbit. Via which fissure? Inferior orbital fissure. So what is the anterior relation? Inferior orbital fissure. What is the posterior relation? Where this maxillary nerve came from? Brainstem, pons, maxillary nerve. Maxillary nerve is giving 3 branches. Maxillary nerve will have several branches, but maxillary nerve, the main trunk, how does it come from middle cranial fossa to enter the pterygopalatine fossa? Foramen rotundum. So, foramen rotundum is posterior relation of, see, from here it will come. So, which nerve is this? CN52. Cranial nerve number 5th, 2nd division, maxillary. Where was it? Middle cranial fossa. How does it enter pterygopalatine fossa? Foramen rotundum. And what happens to it then after giving some branches to pterygopalatine ganglion? It is topographically related with, location-wise related with pterygopalatine ganglion. Then it enters the orbit by inferior orbital fissure and called as inferior orbital nerve. So anterior relation, inferior orbital fissure. Posterior relation, foramen rotundum. What is the medial relation? Sphenopalatine foramen. And what is the lateral relation? Sir has given a very beautiful case. Angiofibroma, is in the posterior aspect of nose, goes into nasopharynx, goes into sphenopalatine foramen, goes into pterygopalatine fossa, goes into infratemporal space, and then cheek swelling. Then only you will have cheek swelling. So what is that canal, sir? That canal has a name where you are basically in the nose, and then sphenopalatine foramen, pterygopalatine fossa, pterygomaxillary fissure, and then the cheek. So sir will be talking about that. I don't want to encroach upon that, but here, see one thing from medial side. Now, if you're looking from medial side, you have taken a sagittal section, and this time you're looking at the other half of the nose, that side. Can you see one opening here? This opening. What is this bone again? Body of sphenoid, the butterfly. This is the leg of the butterfly, which is the pterygoid process. Pterygoid process, body of sphenoid. If this is sphenoid, this is the palate. In the palate, what is most of the bone? That is maxilla. But posterior to that, horizontal process of palatine bone. This is horizontal process of palatine bone. And if you are going higher, then this is perpendicular plate of palatine bone. So sir has told it is like this, isn't it? And if this is palatine, this is the sphenoid. What is this foramen between the two? Sphenopalatine foramen. Or you can say pterygopalatine foramen. But better say spheno because it is body of sphenoid. Through that, the artery will enter, artery of epistaxis, sphenopalatine artery, and then it will supply the nasal area. So this foramen. So what exactly happened? So the angiofibroma case which you are talking about, it is written in the books. First we thought it came from the body of sphenoid. Then we thought it is roof of the nasopharynx. Recently, it is in relation with the sphenopalatine foramen, posterior aspect of the nose.
So there is a small development over there.
Yes.
Even that has been now modified.
Okay.
This is the roof of the pterygoid process, and now we say that instead of the posterior lip, it is near the sphenopalatine foramen and the root of the pterygoid process.
Root of the
So
pterygoid
basically
process.
this area, this small area,
From where small angiofibroma started.
and this is also the place where the Vidian canal opens.
Okay.
So another theory is that the Vidian canal opening maybe, or Vidian canal from inside it may be arising. But basically between what the Scott Brown clearly now says, root of pterygoid process and sphenopalatine foramen, in between them.
And then this has moved, first of all in the nose, then it is nasopharynx, going out into pterygopalatine fossa, then going out into the infratemporal fossa. So that was our case.
Right, sir.
Okay, so as we wind up, you know what is the answer to this question. Tell me. So as we are looking at this question, anteriorly you have superior or inferior orbital fissure. This is wrong. This is inferior. Then medially, what do you have? Towards the nose, sphenopalatine foramen or fissure you can say, but it is not. So posteriorly, do you have this foramen rotundum? I told that the maxillary nerve came from foramen rotundum posterior, then enters the pterygopalatine fossa. So this is correct. That is your answer. What about lateral? Is it sphenopalatine? Sphenopalatine is medial. Pterygomaxillary is lateral. So they have interchanged it. But choice C is the correct pair. That's what we wanted to know. And sir, your question was here. This is your question. And this question was asking about the, sir, it was, okay. So which structure has it crossed? Sir, you please clarify here now.
Okay, so let me go to my...
your slides, right. Sir, these are your slides.
Yeah. So we have the JNA. So symptoms that we made into diagnosis was quite clear. Profuse recurrent epistaxis. There was a nasal, there was cheek swelling over here, and on examination we had this nasal mass. Okay, enhancing mass on CCT. We have seen then there is cheek swelling over here. We can see such kind of a picture was given to us where there was a dumbbell-shaped mass. Okay, and we could see this dumbbell-shaped mass over here also. This is like a dumbbell-shaped mass. It is in the nose, the nasopharynx, and you can see now it is also going to the infratemporal fossa over here. Right? So this is what the CCT is describing to us, and sir has discussed this diagram. All right, this also sir has discussed. Let me just go to Okay, so
Looking from lateral.
yeah, looking from lateral view, you can see the sphenopalatine foramen over here, and then just outside that, you know, this is between the pterygoid process.
Maxillary
Fissure, okay.
To enter the intratemporal fossa.
Yes, sir. And in between them, that shaded part, that is the pterygopalatine or the sphenopalatine fossa.
Fossa.
Okay, and just when we come outside this pterygomaxillary fissure, then this whole shaded area, that is the infratemporal fossa.
That is where it will come to involve the cheek.
Yes, yes, yes. So this whole thing we call the pterygomaxillary tunnel. That's the tunnel, starts from the nasal cavity and then it goes across the sphenopalatine foramen and into the pterygopalatine fossa. Then it crosses the pterygomaxillary fissure and goes to the infratemporal fossa.
So this was our question, pterygopalatine fossa, what is lateral and what is medial?
Yeah.
That relation we wanted to know.
Yeah. And so, Chandal, the question correct. So sorry, that is your question. My question over here. Let's go back. Yeah, so this was the question, which of the following structure has been crossed by this mass?
Cheek swelling.
Cheek swelling. So the answer
Most lateral.
is the pterygomaxillary fissure.
Yes, because this is the most lateral now.
The superior orbital fissure and inferior orbital fissure, it will not cross and cause cheek swelling.
swelling.
It can cross, but it will not cause a cheek swelling with that. Okay, and so the answer is pterygomaxillary fissure.
Great.
Right, sir. So let's go to the next question. So, yeah, 63-year-old male patient. So let's look at the age over here. 63-year-old
We
male
have wide
patient.
range of patients. One is quite young, one is now old age.
So even the age tells you the diagnosis. That's very important. Okay, that's my question. I start breaking down the question from the very first word. Okay, so 63-year male. Sometimes male is also important. Mr. Harishankar Prasad presents in the night emergency.
Sir,
So sometimes.
these kind of questions used to come to us at AIMS in year 2001. Then they disappear.
Yeah.
Again they have appeared.
Yeah, sometimes even, you know, the name is significant, the religion may be related to food habits.
Yes.
Okay, so that may also be there, not in this case, but in some cases. We have to be very careful.
Sir, you have one way of tackling such question. Where do you start? You start with the
No,
options?
I start breaking down the questions.
Okay, okay.
So like in my mind, I'll start encircling the hints. Okay, it's like become the mathematics plus and minus. So emergency with complaints. So emergency, you see, emergency with complaints of epistaxis for past few hours. So rapidly deteriorating. Okay, had to reach to the emergency. Bilateral anterior nasal packing as well as posterior nasal packing was done and bleeding was controlled in the night time. Okay, now nasal pack was removed after 48 hours and epistaxis recurred within a few hours of pack removal. So we know the pack normally we keep for 48 hours. So both anterior and posterior pack were placed. They were removed after 48 hours and bleeding recurred. Now what do you do next? The next step is ligation. So endoscopic ligation of artery of sphenopalatine artery was planned, which was abandoned. So we do a SP ligation. That's the artery of epistaxis sir has been talking. So we decided to a SP ligation. It was planned, which was abandoned midway intraoperatively due to excessive bleeding. Okay, so which of the following arteries can instead be ligated?
Okay, so you have to go for the next
The
better option.
next better option.
Sir, we just have mentioned, we were discussing
Yeah.
maxilla, internal maxillary artery, sphenopalatine artery. If you cannot deal with that, then
The
go
answer,
for the parent.
go for the parent one.
Parent. So parent is, obviously you will have to go for the maxillary artery. And I think there is some specific approach which you will be taking, that you will be talking about. Sir, do we ligate external carotid artery?
Yes, we do ligate the external carotid arteries also. There are cases where we have
What
to.
about the thyroid, sir? Thyroid gland?
So we
Above superior thyroid
so yes, whenever we ligate the external carotid, we have to go above the superior thyroid artery. Okay, so that's the rule. We have to leave that. So the management strategy for epistaxis, I'll just discuss it. So we have seen the patient comes to you, you resuscitate the patient, and the best way is that you do a nose pinching. That's the Trotter's method. I have told you. The patient sits, move tails forward and close the nose for 5 minutes.
Which can be done by medical officer himself without ENT
Yeah,
specialist.
right. And then if the bleeding is visible on anterior rhinoscopy, then we do, that's an anterior epistaxis, we can do a chemical or an electrocautery for that.
Then the ENT specialist should come in picture.
No, even this can be managed by anyone, okay? But if this is not possible, then that means it's a case of posterior epistaxis. And for posterior epistaxis, now the ENT surgeon comes into the picture in the night time. You have to do an endoscopic electrocautery. Okay, so in the night time, let's say the endoscopic electrocautery was not available or the surgeon was not available. Okay, so then we go for, you know, bilateral anterior nasal packing. Okay, and supposedly that fails.
So we have to do bilateral.
Okay, yeah, if that fails, then we have to do bilateral. No, we have to always do bilateral.
Okay.
Because if there is septum bleeding is there, or there is a pressure, if you put on one side, thus it will deviate the septum to the other side. The pressure will not be there. Plus the
Okay, so pressure will be from both the nostrils.
yeah.
Right.
Okay, so whenever we do nasal packing, especially for epistaxis, we have to do it bilateral. Otherwise, as a complication, it will cause DNS. Okay.
Because it is posterior epistaxis, which is quite severe now.
Yeah. So and anyways, after
It has to be bilateral.
it has to be bilateral. It has to be bilateral. And if antenasal packing has failed, that means we have to also do posterior nasal packing. So posterior nasal always comes with bilateral anterior nasal packing. Now, if this has failed, then we go and move ahead. Then we go and do the vessel ligation. So you see, all this was done in the emergency. Till this step they had reached. So maybe endoscopic electrocautery was not possible in the night time. See, a question mentioned, patient presented in emergency in night. So this was not possible, this was not available. They did packing, bilateral, anterior nasal and posterior nasal. Now that failed after 48 hours. So ESPAL, endoscopic sphenopalatine artery ligation was planned. Okay, now this also failed. So next step is internal maxillary artery ligation. And if that fails, then we go for external carotid artery ligation. Right? Okay, so this is the endoscopic sphenopalatine artery ligation. You ligate it, and anyways there is this thing, the whole, you can see that everything has become pale. So because the sphenopalatine artery, that is the major artery for the nasal cavity. Alright, we have to go for internal maxillary artery ligation. We can go it two ways. We can go it endoscopically. Okay, so endoscopically or through the antrum, two ways. So number one, you can see over here, this is the antrum.
So this appears to be internal maxillary artery. This is the foramen where it is giving sphenopalatine.
Yes, sir. So this is the antrum.
Okay.
This is the maxillary antrum.
Right.
Okay, and this is the
Ostium.
This is the nasal cavity. Okay, the septum. So this is the inferior turbinate. So we just cut it to show the approach. And this is the internal maxillary artery coming from the inferior infratemporal fossa, okay, to the pterygopalatine fossa over here. That's the pterygopalatine fossa, and this is the sphenopalatine foramen, and from there it is coming to nasal cavity.
Right.
Okay, and so I'll just clear all the ink over here, and we can see once again I have marked all these structures over. That's the sphenopalatine foramen. Okay, now those are the pterygoid plates. Okay, so first approach that we can take is we can go transantral. That's known as Cardwell-Luck operation. So we give a sublabial incision. We break the anterior wall of the maxilla. We enter into the maxillary antrum. That's known as Cardwell-Luck operation. Then you break the posterior wall of the maxilla, and you are directly at the pterygopalatine fossa, where you can find this IMA and you can ligate it. Okay, so that's one approach. The other approach is you can go endoscopically. You can open the maxillary antrum. You can again go transantral. You can open the maxillary antrum from the ostium. Previously it was done through the inferior meatus approach. Nowadays endoscopically we do from the middle meatus approach. We open the maxillary antrum, and then again we can break the posterior wall of the maxilla, and we find the internal maxillary artery. So this is in the CT scan. The two approaches have been shown: the transantral approach and the transnasal approaches. Okay, and this is the Cardwell-Luck approach, where we are giving a sublabial incision. We are entering into the antrum.
So sometime, if bleed is there, you just remove the mucoperiosteum if recurrence was there and put it back. Fibrosis, it prevents recurrent epistaxis. Is there some procedure like that?
Yeah, so that was done earlier. That is if the bleeding is from the
So
septum.
I am from old school now.
Yeah, so that is the bleeding from the septum is there.
Okay.
Okay, especially in the littles area, if somebody is having recurrent epistaxis.
Right.
So it was believed earlier that you raise the mucoperiosteum or mucoperichondrium, and that will hamper some of the blood supply and put it back. Okay, but nowadays what we do is that we go for ligation of the vessel, which is supplying the. Because that procedure is questionable, it may not always hamper the blood supply. So patient may still have problem. But when you ligate, it's a definitive treatment. Okay. So and if all that fails, then we of course have
So that is where we mentioned like we have to ligate it, but after giving the superior thyroid.
superior, and we have to be very careful. Okay, we always ligate the external. We never ligate the internal carotid artery. Right, sir.
So that came as a question.
Yeah, that came as a question.
In epistaxis, ligation is done in all the following vessels except internal you cannot. So here I will just show. I have this thing here. I think I had a question for this as well. This was my question, I think. Yeah, which of the following is branch of internal carotid? So it is actually Kieselbeck plexus, that is the little's area. You have a anastomosis kind of thing between the internal carotid artery branches and external carotid artery branches. So we have a diagram also where we can talk about that, and I think you already know the answer. Internal carotid artery will be giving us anterior ethmoidal artery for Kieselbeck plexus, though it also gives posterior ethmoidal artery to supply the area, but Kieselbeck plexus anterior ethmoidal artery is important. So you can make out your answer that this is actually a branch of the internal carotid and cannot contribute to Kieselbeck's plexus. Sorry, what is this? What is this question asking? Internal carotid, right. And sphenopalatine, we know maxillary artery, external carotid artery. Greater palatine is again a branch of maxillary artery. Septal branch of superior labial is a branch of facial artery, is a branch of external carotid artery. Sir, I have a diagram for this. Just, yeah. So here you can see, we understand that there will be this common carotid artery coming, and this common carotid artery is bifurcating, so that we have internal carotid. Sir is telling never go for internal carotid artery, for obvious reasons. It is going to enter and supply the brain area. So external carotid artery keep giving certain branches, like we told, you have to take care of superior thyroid artery. Beyond that only you have to ligate. And then you have the facial artery. Facial artery giving superior labial, and that superior labial contributing to antero-inferior aspect of the nasal septum, Kieselbeck's area. So this is facial artery, and then maxillary or internal maxillary as we are telling, which itself is giving two branches, sphenopalatine artery and the greater palatine artery. So sphenopalatine, greater palatine or septal branch of facial, they are all from external carotid artery. So what about internal? See, this is the internal carotid artery coming here, and it is now giving us ophthalmic, and then it is giving us the posterior ethmoidal and the anterior ethmoidal. It is the anterior ethmoidal which is contributing to Kieselbeck's plexus. Right. Sir, please.
So this ophthalmic, this is the first intracranial branch of the ICA. That's a question which is asked. It is given just before it forms the circle of Willis.
Circle of Willis, right.
And this is the one that will give the posterior ethmoidal and the anterior ethmoidal. The posterior ethmoidal will not contribute to the Kieselbeck's plexus, whereas the anterior ethmoidal contributes to the Kieselbeck's plexus.
And as sir was suggesting, we have to basically ligate the sphenopalatine. But if you could not, then you have to go for internal maxillary. If you could not, then you have to go for external carotid, but only after giving superior thyroid artery.
And sometimes if even this measure does not control the bleeding, if there is a tumor like a JNA and we have controlled this ECA and still there is a bleeding, that means it is coming from the anterior ethmoidal artery. So we can go for an endoscopic ligation of the anterior ethmoidal artery. Posterior ethmoidal artery is generally very small. If you put a pack over it or you pack it overnight, this will not give any bleeding.
So these bleeds will be above the middle turbinate.
Yeah, so both of them will be above the middle turbinate. In fact, posterior ethmoidal bleed is above the superior turbinate also, but this will not give so much of trouble. The main trouble after ligating the ECA will be given by the anterior ethmoidal artery.
Right. Fantastic. I am an old school person because obviously ENT is the territory of Dr. Sarvejeet, and he is, take it from me, the most updated person I have ever seen. Though PrepLadder has a lot of faculty who are brilliant, but when it comes to updates, I cannot, appreciate my efforts, but more than mine effort, Dr. Sarvejeet I have seen, and it is a sincere statement which I can make on his face. I have seen personally. I have felt.
So most of you, I'm very happy to have this discussion today, and most of you may not be knowing, but sir has been my teacher when I was preparing for the MBBS exam. After the MBBS, my PG entrance exam. So it's like 17 years, and I've been waiting for the moment when I can come and share a dice with him. So he's been my idol, and it's very happy to have him here and share this dice with him.
Triple vaccinated, so no, but still, this Omicron is evading everything. Anyhow, I think our immunity is quite good at the moment.
Yeah, right, sir. So thank you very much. I hope you also enjoyed the session just like we did today. I really enjoyed it, and I learned a lot from him, as I have always learned from him, and it was for me.
It has been a great pleasure being as a student or as a colleague and sharing the same stage. It's always a pleasure to interact and be in the vicinity in company of people who are sincerely trying to justify their role as a surgeon, as a teacher, as a editor of the books, whatever, and even the technology wise also he is brilliant. So it was a nice session. I hope it has helped you, and if you have queries, you can always put in the chat box. We'll just go through the chat box, because at the moment we are not looking at the chat box, so we'll try to answer back.
Right.
Okay, take care, all the best.
Okay,
Sir.
best of luck. Thank you.